and welcome to Identifying Suicide Risk with Dr. Lisa Horowitz and the ASQ Suicide Screening Tool. I am a mental health and suicide prevention speaker, and I am sharing this event today in memory of my son, Charles, who died by suicide 10 years ago in 2015. And why is this topic important specifically to me? In the last 2 weeks before his death, my son was at a medical setting, and one for a sprained ankle, one because they took him to the hospital after he relapsed to see if he could go through detox again. And one was to a psych hospital where they specifically asked for a risk screening, and they turned him down because they didn't screen those people anymore, meaning people who were addicted to heroin. And that made my son feel like garbage. So I don't know if it would have saved his life or not. But I do know that those were 3 missed opportunities. And I want every medical setting in the country to do this 20-second screening tool. And you'll see why as Lisa Horowitz goes through her presentation today. So I want to also say this is sponsored by Zero Suicide, and I'm going to put their link here. Thank you for that. And together we also did a video together, an award-winning video, and I'll post a link to that, called After Your Child's Suicide Attempt. Now I want to introduce my friend, Dr. Lisa Horowitz. And years ago, we presented together about this tool. I would spend a few minutes telling my story, and then everybody would be very engaged with her presentation. And I'm deeply honored that she decided to do this today because her schedule is very full. And Dr. Horowitz is a pediatric psychologist and senior associate scientist at National Institute of Mental Health. And the major focus of Dr. Horowitz's research has been in the area of suicide prevention in the medical setting, and is also one of the co-authors of the Blueprint for Youth Suicide Prevention, released by the American Academy of Pediatrics. So without further ado, if you want to go ahead and get started with your presentation, Dr. Horowitz.
Sure. Can you see that screen?
Yes, everything looks good.
Okay. Well, first of all, thank you so much, AnneMoss, for inviting me to talk. It's such a privilege to be, first of all, doing anything with you. You're one of my suicide prevention champion heroes, and I'm just so impressed by all the impact you're able to make. And it's such a privilege to be here speaking to all of you, because you're all people that can reduce suicide. Because anyone who's interested in starting the conversation, and that's what we're really going to focus on today, a screening tool is a research-based, standardized way to give a healthcare provider a standardized way of asking really awkward questions and starting a really difficult conversation with a patient, but a really important. So we're going to talk about that today. If we were in person, I would ask for a show of hands for anyone who's lost someone to suicide, and inevitably, either personally, professionally, inevitably every hand would go up, because even though suicide's a relatively rare event, the ripples effects are endless and they affect us all. So thank you for your attention today. I'm going to make sure we have a lot of time for your questions and discussion. And so I'm going to start I have to start with this slide because I work with the federal government. This is NIH in Bethesda, Maryland, National Institutes of Health, and I have no financial conflicts to disclose. So I'd like to start with my take-home message, right? We're going to be talking about youth suicide. It is a major public health crisis now, and there are significant disparities that so it's not even, and we're going to talk about that. And like I said before, every one of you could help reduce suicide, and it starts with a conversation and asking directly. And we're going to talk about suicide risk screening tool called the ASQ or the ASK. And that's a way to identify people at risk. And then we've come up with clinical pathways so that those people who are at risk can get help. So I believe, and I'm a big advocate for universal suicide risk screening for that reason that AnneMoss said, had her son gone to the pediatrician's office and they had screened him, he would have had a chance. He had 3 chances where someone could have identified his risk and helped him. So how do you do this without overburdening very busy healthcare providers? And so we believe in this 3-tiered clinical pathway. It starts with a brief screen with the ASQ, which I'm going to tell you about. And then one of the most important parts of the pathway is the brief suicide safety assessment. And that's where, so anyone can do the screen, but a clinician needs to do this next step. It's not a full mental health evaluation. It actually is the next, it's a further triage of the screen to see what does this patient need next to help them, and then identify these next steps that you're going to take. So you're going to hear me talk about this pathway a lot. So first, I just want to go through a brief epidemiology of suicide. It is the second reason why young people die. And when I'm talking about young people, I'm talking about people under the age of 25. Young people aren't supposed to die. They're supposed to grow up and live long, healthy lives. But if you look at the number of youth deaths in 2023, almost 20% of those deaths were from something that is potentially preventable, suicide. Now, I'm going to say potentially preventable because not every suicide is preventable, but 20% is a staggering number of deaths we should be able to prevent. So this is the suicide rate over time. And as you can see, starting in 2021, we see a very little bit of a dip that I'm hoping is a trend, and we won't know this until we have more data points. But hopefully, all these national efforts to reduce suicide are taking hold. So we'll see. So suicide, there's many underserved and understudied populations that are at greater risk. So there's risk by race. American Indians have the highest rate of suicide than any other race or ethnicity. Black youth suicide is on the rise. But the high risk populations are not just, with races and ethnicities, but also people who identify as LGBTQ+. Those people are at higher risk. People with neurodevelopmental disorders like autism. Kids in the child welfare system are about 6 times the risk of dying by suicide. Anyone in a detention center and people in rural areas. These are all underserved, understudied populations. So we think that universal suicide risk screening could really bring some health equity, right? Because it's not, because targeted screening is just, I'm going to screen you, but not you. But universal screening means that you're screening everyone. So everyone has a chance to get help. Now, this is the suicide rate by ethnicity that I talked about. And you can see, you don't have to know graphs even to just see this gray line. That's an outlier. Those are American Indian, Alaska Natives, and you can see that it disproportionately impacts young people. So I'm a pediatric psychologist. I focus on youth, but a lot of what I'm going to talk about today also has to do with adults. So there is a child mental health crisis. This was declared a few years ago. The Surgeon General put out an advisory on it in 2021. The trade groups like American Academy of Pediatrics, Child and Adolescent Psychiatry, Children's Hospital Association, they all declared this children's mental health emergency, right? So why are kids so challenging to treat, right? And I just want to show you very briefly, kids develop at different rates and at different times. So there's no one uniform way, but all these things on the left here: physical growth, motor development, language, cognitive, emotional attachment, sexuality. These are all going on at different times in different kids. And so it's really hard just to have a one size fits all approach, especially something like suicide risk. So that's why kids are just a little bit more challenging, because they're developing beings. But we have to stay on top of this and make sure we're seeing when something isn't going right. So let's talk about the spectrum of behaviors, right? When does something go from everyone's got some depression and anxiety and worries and all kinds of things going on, mental health problems. When it becomes a disorder is when it starts to impact functioning. Everybody's got some of those, but then when they stop getting out of bed in the morning, right? When kids stop wanting to go to school, when they're not getting their work done, when all of a sudden somebody who was taking showers stops and they look different, or all of a sudden, especially for kids, they're in a bad mood all the time when their personality wasn't like that before. Or you see some sleep and weight changes, or they're starting to be isolated, like they're not as socially active with their peers, they're not talking to family members like they used to. And again, this is important that you're seeing a change. This is not saying people who didn't do this before, there's a problem with. It's the change. They're not acting like themselves. All of a sudden, it goes from experimenting with drinking and smoking to excessive use. And then sometimes they even talk about suicide and death. And these are all when something is moving from just being a mental health concern to a mental health problem. Now, I just want to talk about, there's no one event that causes suicide. Sometimes people look at the last thing that happened and say, oh, that's what happened. And, there are triggering events to someone who is in a vulnerable state, someone who is suffering, and then maybe something happens that throws them over the edge. But there's not just one thing that causes suicide. So I'm saying this because there's plenty of time for interventions beforehand. But examples of triggering events are things like when people break up in a relationship, or bullying, or school academic problems, being rejected by peers, or feeling like a failure, or if you have a death in your family or someone dies of suicide that these are all warning points of like when you should pay extra attention to someone who is already vulnerable. So these are the risk factors for suicide. Now, I'm not going to go through every single one, but I highlighted the most potent risk factor is previous attempt. So anyone who has tried to kill themselves in the past is more at risk for doing it in the future. And mental illness, I'm going to show you a slide that shows that the majority of kids who die by suicide do not have a diagnosable mental illness, but mental illness is still a risk factor. And then medical illness, that's a risk factor that we often overlooked. Now, these are risk factors. So most kids and young people who have these risk factors are not going to die by suicide. Risk factors help us with research and maybe trying to see if someone's at risk. But what's really more important to pay attention to, other than the risk factors, are the warning signs. So warning signs are things that absolutely you need to pay attention to. And the first one sounds so obvious, someone talking about wanting to die or kill themselves. But this, especially in young people, is often not paid attention to. And one time I was part of a study of preteens, and it turned out that a third of them that had died by suicide had told an adult that they were thinking about it. But a lot of times we don't take it seriously. So it's really important to take talk of suicide seriously in everyone. Someone who's looking for a weapon where they weren't doing that before, or feeling hopeless, trapped, or like you're a burden. Again, excessive use of drugs or alcohol, or the signs of depression, sleeping too little, too much, feeling isolated, severe mood swings. These are all warning signs that need to be paid attention to, because someone might be at imminent risk for suicide. And that's the old suicide lifeline. It has been replaced with 988, which we will get to in case you don't know about that. Okay, that is not anything to do with suicide. That is my daughter's cat, Giuseppe. And the reason why I'm showing you Giuseppe is because I just laid some very heavy, sobering statistics on you. And of course, talking about suicide is very serious. But this is not a depressing webinar, because this is a webinar about hope and action. And anything I do with AnneMoss Rogers is about hope and action, because she's someone that turned grief into action. And there is so much we all can do to prevent suicide. So that's where we're going to turn our attention to. And it's a good time to talk about suicide, because celebrities and athletes now are not staying muted with this, right? They're talking about depression. They're talking about their thoughts on suicide. And so it's a good time to have these conversations. Now, it's also, this is the what pediatricians screen for. I'm not expecting you to read this. I wanted just to show you because it's so dramatic. This is all the things that pediatricians need to screen for. Okay, and the American Academy of Pediatrics Bright Futures puts this out, and according to age. But what's so exciting to me, and I think this is the best thing to happen to suicide prevention in a medical setting, is in February of 2022, the AAP declared suicide risk screening as something pediatricians should do alongside depression screening. And they picked the age of 12 years and above, and they picked 12 to align with depression screening because that was already out there. I'm going to try to convince you that we should go down to 10, and that's work we're doing with the AAP as well. So I'm fortunate enough to be part of a research team that asked, can we save lives by screening for suicide risk in medical settings? And I think this is absolutely a great place to save lives. And the reason is, it's just what AnneMoss said in the beginning. The majority of people who die by suicide, and this is not just adults, but young people too, have visited a healthcare provider, not just months, but sometimes weeks, sometimes within a week before taking their own life. But the problem is they don't come in and say to the doctor or the nurse, I'm thinking of killing myself. They're coming in with medical complaints, right? So if someone doesn't ask them directly, are you thinking of killing yourself? They most likely won't talk about it. So the majority of suicide attempters go unrecognized because the majority of medical settings don't screen for suicide risk. And this is the other piece of data that came out this past fall. That there was a JAMA study showing that 60%, that's most, right? 60% of young people who died by suicide had no documented mental health diagnosis. This is the best evidence for why we should do universal suicide risk screening, why every child over the age of 10 in pediatric practices should be being screened for suicide risk. Okay, so when we did some of our studies, we asked the parents, when we did some of our screening tool development studies, when we were testing it, we said to parents, do you think kids should be screened for suicide risk in medical settings? And I want to show you, and this study was, several years ago, and maybe things have changed, but we collected voluntary anonymous parent survey. And the majority of parents did think their kids should be asked. It was about 70%. It wasn't 100, it wasn't 90. Parents were a little bit on the fence. And the common themes of them being in favor was they felt like maybe their kids will be more comfortable sharing with the doctor than a parent. They felt like suicide prevention was important, and they thought that it destigmatized the conversation if pediatricians brought this up with all the other medical things they're studying, right? They're asking about, right? And then the common things that there was about 15% of parents were against screening, and they said things like, this is going to make my child feel uncomfortable. You're going to put the idea into their head where they weren't thinking about it before. Now they're going to be thinking about it. And they're here for their medical bodies stuff. They're not here for mental health stuff. So I'm going to show you things that refute all three of these things. Suicide screening absolutely does not put ideas into people's heads, and I'm going to show you that. And you can't really have physical health without mental health. We know that. And sometimes questions are uncomfortable, but that's what we're trying to get through. Okay, so what do you think is the most common reason why people don't ask people, not just kids, but anybody, about suicide risk when they're worried about them? So just think for a second, what do you think? So people are afraid you're going to put the idea in their head. So I don't want you asking my kid about suicide risk. Maybe he wasn't thinking about it. Maybe you're going to make him think about it. But you don't have to take my word for it that it's safe. There's at least 4 studies now showing that it's not only safe to ask kids about suicide risk, but it is a way to save their life, right? So it's not only not harmful, but it's helpful. If someone wasn't thinking about suicide before and you ask them, you are not putting the idea into their head. What you're doing is you're recognizing a warning sign and you're starting a very awkward but critical conversation. Now, there is a difference between asking very compassionately someone that you care about, are they thinking about suicide, and putting it on TV in the dramatization, right? So I was part of this study where we looked at what happened when 13 Reasons Why, which was a Netflix series, was released. And it turned out that there were 212 excess suicides that occurred after they released 13 Reasons Why than was expected in that year. And that's because it was a dramatization. The person who died was in every episode getting revenge. There were no trusted adults that did anything when people were reaching out for help. So there could be suicide contagion when vulnerable kids watch media about suicide risk. So this is very different than putting the idea. This is a vulnerable kid watching something that's dramatized and then getting, thinking, oh, okay, that's an option. So 2 different things. Okay, this is a link to an amazing video that I'm going to ask you to watch on your own time. It's 4 minutes. Christina's going to put the link in the chat, but it's also Google. You can Google it if you just say Mayo Clinic public service announcement, teen suicide, it comes up. It's a wonderful video. All parents watch it. I even show it when I do adult trainings because they're talking about kids, but it's really good for adults too. Okay, so we're going to talk about screening, but I want to start by telling you the difference between screening and assessment, because people mix these terms up, right? They use them interchangeably, and they are absolutely not interchangeable. So screening is a very brief way to identify someone who needs further assessment, right? It's quick. I'm going to show you a 20-second screening tool. That is very different than the assessment, which is a more comprehensive evaluation. It confirms risk and it guides next steps. So keep this in mind. If you hear someone interchanging screening and assessment, stop them, because screening and assessment are 2 different things. So what are the valid questions that nurses, physicians can use to screen medical patients for suicide risk in a medical setting? This was our research question, right? Because and you might ask, well, why do you need research-based questions to ask people? Well, I'll tell you, when you don't study a question, you don't know what it's really asking, even if it sounds like it's asking the right thing. I know a hospital, a cardiac unit that saw adults with cardiac disease and made up their own screening question. So they said, have you ever thought about suicide? Well, that screening program was shut down in 3 days because their psychiatric services could not handle all the positive screens, because they weren't asking something that was specific enough, right? Have you ever thought about suicide in your whole life to an adult with cardiac disease? it was too broad a question. So you need research-based questions. So we launched this study. It was called the ASQ Suicide Screening Questions study. It was 3 pediatric emergency departments in Boston, Washington, and Columbus, Ohio. We had medical patients. We had patients presenting with psych. And they trickled down to kids. This started with kids and is now. This is the ask. It's meant to be very blunt and very direct. In the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And have you ever tried to kill yourself? If the patient says yes to any one of those 4 questions, you ask a 5th acuity question. Are you having thoughts of killing yourself right now? Now, what I know from really big data sets, so there's one hospital in Dallas, Texas, that we did a study with, Parkland, where they now have screened millions of patients, but we wrote a paper on 90,000 asks that they gave. And what we know is that from this paper is that 97% of the patients screen negative. And, it might matter if you're an emergency department, it might be a higher screen positive rate, like 6 or 7%. Primary care might be 3 or 4. Older kids might be 10%. The rates of screen positive vary, but what we know is the majority of patients you're going to ask this to are going to be negative. Now, the reason I'm emphasizing this is because this is not overburdening busy healthcare systems because of these numbers. So most patients screen negative. It's 20 seconds. It's done. And also you just destigmatize suicide because you're saying this is important. And you can, when you get a negative screen, you can say, if that ever changes, please let me know. However, there are positive screens, and that's why we do it, right? So if someone says yes to any one of the 4 questions, you ask the 5th question, are you having thoughts of killing yourself right now? The most common way to screen positive is a non-acute positive. You can either be non-acute or acute. Out of this one study, 99.5% of the positive screens were non-acute positive. So the majority of patients who screen positive, who are telling you they're thinking about suicide, might not be an emergency. Something to absolutely pay attention to help them with, but not a trip to the emergency room, a paper gown, a sitter. However, you do have to be ready for that yes, which is the acute positive. And that is an emergency, and that might be a trip to the emergency department. So we're going to talk about the different ways to interpret the results. I will tell you that the ASK has been tested in all medical settings, inpatient, outpatient, specialty clinics. It had a multi-site study in adults. And then those places in black are ongoing research. We're so excited about our partnership with the Indian Health Service. The Indian Health Service has now mandated that all 130 facilities around the country use the ASK as their suicide risk screening tool. We just finished training 10 regions to do this in their medical facilities. And starting September 1st, they're all going to go live with this. The ASK is also translated into over 23 languages, and those places in green are home countries that have tested the ASK, and it comes with a toolkit, and that is available at the bottom of your screen. Okay, so one of the questions I got, so that's the ASK. That's meant to be a screening tool used by healthcare providers. One question I got when the AAP said screen for suicide risk alongside depression was, a lot of pediatricians were already screening for depression. Can't we just use that as our suicide risk screen? So the answer to this is no, but I'm going to show you why. So the PHQ-9, very good depression screen. A lot of healthcare settings use it. It's a great depression screen. It has a 9th item that is used as a suicide risk screen. And the question says, how often have you been bothered by the following symptoms during the past 2 weeks? Thoughts that you would be better off dead or of hurting yourself in some way. So there's three things wrong with this question, right? First, it says bothered. There are some kids that are unfortunately are not bothered by these thoughts. So one, you have to be bothered. Two, it has an or in it. If a question has an or in it, you don't know which side of the sentence the patient's responding to, right? So it both over and under detects. For example, that cardiac clinic, if you asked a 60-year-old who's had chronic illness their whole life, if they had thoughts they'd be better off dead, they might say yes. It doesn't mean they're thinking of suicide. It might just mean they think that sometimes, right? And then the kicker is really hurting. It says hurting and not killing. And we know, especially young people, think of hurting and killing as two different things. So this is not a sufficient question. And now there's at least 13 research studies showing that the PHQ-9, while being a good depression screen, is not sufficient to identify people at risk for suicide. But we wanted to test this out. So when we were testing the ASK on the inpatient medical surgical unit, we had 600 kids, 81 screened positive for suicide risk, 103 screened positive on the PHQ adolescent version, PHQ-A, and 42 endorsed that 9th item. And if you put this together, what you find is, had you only given the PHQ, you would have missed a third of the kids at risk for suicide. And had you only done that 9th item, which lots of places do, you would have missed over half the kids at risk for suicide. So these findings really show us that while it is so important to screen for depression, absolutely, it's also important to use a suicide risk specific screening tool to screen for suicide risk. Now, there's also places that screen like this sequentially. They start with 2, PHQ-2. If that's positive, they give the PHQ-9. And if that's positive, those are the kids they screen for suicide risk. There is no evidence that that's a good way to screen for suicide risk. I can't tell you one study that showed this is an effective way. And also, why would you make the patient jump through all those hoops? So pediatricians told us we want one tool. We want one piece of paper. We don't want all these different pieces of paper. So we stuck the ASK on the bottom of the PHQ-A, and now you can have suicide risk questions that are evidence-based. Okay, so like I said before, the ASK has to be part of a 3-tiered pathway. Starts with the brief screen, then the brief suicide safety assessment, and that helps the clinician determine what does this patient need next. So a screener, and this isn't a training, this is just to tell you about it. Anyone can screen who's trained, and anyone can be trained to screen. It's usually a nurse, a medical technician, a medical assistant, but sometimes it's a physician, sometimes it's a fellow, sometimes it's a resident. And then you tell the parent or guardian to step outside so you can screen in positive. If they won't leave, you screen in front of them. The ASK has to be administered exactly as it's written because it is an evidence-based tool. It's scored in real time, and the findings have to be reported to the medical team before the visit starts or as soon as possible, because if you know there's suicide risk, you want to make sure that who's ever evaluating this child has time to evaluate for suicide risk. We're recommending that you universally screen everyone who is cognitively able to answer questions, medically stable enough to answer questions, 10 and over. For kids 8 to 10, we think you should screen when it is clinically indicated. So for example, if they're presenting with a mental health chief complaint, you should screen them. And there's no suicide risk screening tools for kids under the age of 8. So clinicians need to be trained on the warning signs. If a parent comes in and says, every time my 7-year-olds, every time I discipline them, they grab their throat and say they want to die, that's a warning sign. You don't need a screening tool. You just heard that they're at risk. You need an assessment. Okay. So what happens when the patient screens positive for suicide risk? Well, here's what should not happen. We cannot treat every young person who has a thought about suicide like they're an emergency, because this is the worst thing, really. They're in a pediatrician's office. Maybe the screener is the first person that's ever asked them about suicide. And on this day, they were brave enough to speak about it. And now they're sent to the ER and they're put in a paper gown and their phone's taken away and they're given a very costly one-to-one sitter and they're there for hours. And this patient might be sorry that they ever spoke about it and may never speak about it again. So this feels punitive. This clinical pathway is a guide to help avoid these unnecessary interventions. Now, sometimes a patient is at risk for suicide and is an emergency and does need to be sent to the ER. But when that happens, we have to train people to be so compassionate and explain why their stuff is being taken away, why there's a security guard outside their door, because safety is the most important thing and it has to be done in a compassionate way. Okay, so there's 2 ways to screen positive on the ASK. I'll go over the emergency is the acute positive. That's yes to 1 through 4 and a yes to 5. This means you do use your high-risk procedures. Patient can't be left alone. They need someone watching them. Any harmful items that can be removed from the room should be removed. They need an urgent, full mental health evaluation. And they can't leave wherever you are until they've been cleared for safety. So we're all mandated reporters of people who might be at risk of killing themselves. And so that's why they can't leave. However, this is unusual. It happens for sure, but it's not the most common presentation of a positive screen. The most common presentation is a non-acute positive. It means they told you something. They said yes to at least 1 question. They said no to the 5th question, which is, are you thinking about killing yourself right now? This means you detected something important, but it's not an emergency. And so they need a brief suicide safety assessment from a clinician. If they can be left alone, we work this out with the Joint Commission. If there's no other safety concerns, they can be left alone. And if their parent decides that they don't want to stay for this brief suicide safety assessment, then they're not tackled in the hallway. They're not treated like, some criminal. The clinician documents the refusal and decides how to discharge them. Sometimes it's against medical advice, but probably not often, right? Sometimes it's a follow-up phone call the next day. Hey, I want to check in on you. So we're trying to make this more patient-centered and compassionate care. You don't have to read this. This is what a fleshed out pathway looks like, where this is our outpatient pathway. But it comes down to those 3 steps. It really is this. And what I've learned now from observing and consulting on suicide risk screening implementations all over the country is that while these are the 3 steps, there's 100 different ways to do them. And the nuance matters. And so how you make that happen at your setting really matters. And you do it through a quality improvement process, and it's a repetitive, iterative process where you keep trying to make it more efficient. So just very briefly, the brief suicide safety assessment ideally is done by a social worker, but most places don't have the luxury of a social worker. So another clinician, a nurse practitioner, a physician assistant. In the Indian Health Service, we train pharmacists to do this next brief suicide safety assessment. Residents, trainees, fellows, those kind of clinicians can be trained. There's 2 tools people use, either the Colombia Suicide Severity Rating Scale or the ASK Brief Suicide Safety Assessment, which we made so people could do this further triage of the ASK. But really, whatever tool you use, it's helping the clinician decide what are the next steps for this patient. This patient screened positive. Are they imminent risk and they need an emergency visit? Are they low risk and nothing more has to happen at this time? Or the harder category is the yellow. You identified something, it's not an emergency, but they need further evaluation as soon as possible. So we have 6 versions of this. Actually, we have 8 versions because we have a telehealth version now. They're all available on the NIH ASQ Toolkit. But I want to pay special attention to the person that connected I had a pediatrician superhero connect AnneMoss Rogers and me together, but he was Dr. Ted Abernathy, or he is Dr. Ted Abernathy. This is him right here holding the dog. I gave one of these talks to the American Academy of Pediatrics, and he said, I want to do screening in my practice. I don't want I don't want anything to ever happen to any of the kids I'm seeing. So he was a big test site for us. He really helped us tweak and revise. That's his staff with him. So I always like to credit him during this. Now, sometimes I will train a pediatric service that wants to do screening, and they'll say to me, you know what, we can't really do this because we don't have any access to mental health care, which unfortunately is happening throughout our country. And so there are 3 brief interventions that everyone can do that makes a difference, right? So if you don't have access and you can't get a full mental health evaluation, there's still 3 things you can do for that patient, right? There was a rural clinic, and they stopped screening. They told me their screen rate was too high. They just can't ask anymore. And I told them, these kids who are thinking about suicide are thinking about it, whether you ask them or not, they're still thinking about it. So let's come up with 3 things you can do. You can do safety planning. Everyone can be trained to do a safety plan. You could do lethal means safety counseling. How do you make sure that the house is safe so they don't have access to something? And you can provide 988, which is a lifeline for many people. So there are things you can do. A safety plan, we won't have time to go into all that goes into a safety plan, but you have the patient talk about what are their warning signs. Every time my parents fight, I feel like killing myself. Every time my ex-girlfriend calls me, I feel like killing myself. What are your coping strategies? What are you going to do if it's 2 o'clock in the morning and you're thinking of killing yourself? You have them generate the ideas. I'm going to write in my journal. I'm going to exercise. I'm going to listen to music, whatever it is. Who are their supports, their emergency contacts, and then how are they going to reduce access to lethal means? So important to reduce access, because when someone's in a suicidal state, they're not thinking clearly. Their brain isn't working, right? So if something's around, like a firearm or a pesticide or pills, they might do something to harm themselves because they're not using their good cognition. So it's really important to keep the house safe, and then to provide resources like 988 and the crisis text line. And then, as AnneMoss Rogers stated, when the American Academy of Pediatrics came out with their recommendation, we created this blueprint for youth suicide prevention. So I encourage everyone to go to aap.org/suicide prevention. Such a wealth of information on that website. So we started with the ASK in these 3 states. It's being used all over the country now. It's being used in different parts of the world. These are some examples of children's hospitals that are using it. And so I just want to finish up because I do want to get to your questions. I have a few more minutes. After you ask, what do you do, right? And so I ask anyone who's never done this before to go home tonight while you're brushing your teeth and you're looking in the mirror and practice. What are you going to do if you ask someone, are you thinking of killing yourself? And you get anything other than no. You get sometimes, maybe, yeah. What are you going to do? You can't panic, right? Because now they're telling you they've decided to open up. It's important to listen actively, listen, be present. And then if you know them, you can provide hope and strength, right? I've seen you've been through hard things. I know how resilient you are. We're going to get through this together, right? You can connect them with a mental health professional as soon as possible. You can make sure that your child has a trusted adult. You can tell parents, if you work with parents, a lot of times that trusted adult is not the parent. In fact, most time it's not, and it's okay. It doesn't mean they're a bad parent. Also, if a parent misses a suicide attempt, it doesn't mean they're a bad parent. It doesn't mean they weren't paying attention. Kids keep these thoughts to themselves. And also, these are hard things. These are hard things to talk about. These are really hard things to fix, but people need help. And so they do need to have a trusted adult in their life that they talk about. And then every child should have a safety plan, lethal means safety counseling, and 988. And then it's important if you work with parents to encourage things like family dinners. These are places where, even if everyone's so busy now, but even if you can do the family dinner once a week or once every 2 weeks, car rides, those are great times to talk to kids about what's going on with them. Because they're captive. They're in the car with you, right? Ask open-ended questions. Don't ask yes or no questions. Ask questions like, so tell me something that has been challenging for you in school this week. Be present, be curious, guide by your own example, handle your own stress in a way that shows them, because even if they're not talking to you, because they're teenagers, they're watching what you do, right? And then for parents of kids that are going from childhood to teenage or years, you want to transition from being the manager of everything they do to being a consultant. Okay. And then how do you engage these kids that are what I call eternally earbudded, right? So you talk to them. I notice you've not been yourself lately. Is there something bothering you? That's a good opener for these awkward conversations that are not easy to have. I know you feel awful right now. I promise you will not always feel this way. You can say, what's your take on that thing I saw in the news about that, and whatever it was. Do you know kids who think about suicide? Tell them about your mistakes. Don't make it look like everything you do is perfect. You don't have to role model perfection for them, right? That's a good way to show them that adults mess up sometimes. And then this is what they do when they mess up. And then they're watching you, even if you think they're not listening anymore. These conversations are so hard to have. And I say that I'm trained, to assess someone for suicide. And every single time I go for a suicide risk assessment and I send a patient home rather than to the emergency room, I walk away with like white knuckles and I just pray that I did the right thing, right? That I made the right decision, because it's so hard to know and you never really know. And then if someone in my personal life, if I'm worried about them, this is not an easy conversation to have, even for someone who knows the words. It's always awkward, but it's always important. And you can foster resilience. It's important that you let someone know that resilience is messy, right? It doesn't mean that you don't struggle. Like I had a friend who was like, oh, I'm sorry, I'm crying so much, or I had a little breakdown, or that's okay. That doesn't mean you're not resilient. Things happen that make you cry, that make you have a breakdown. It doesn't mean you're immediately okay when something bad happens. That's not what you need to be resilient. You need resilience is getting through hard times to another side where then you thrive. And a person who falls and gets back up is much stronger than a person who never fell. So these are some, we can put this in the chat too. This is the Seize the Awkward campaign that the AFSP puts out, where there's videos of how to start these awkward conversations. And I'm just going to wrap up with this one example from Dr. Abernathy's practice. So important. I told you that when you screen, you screen with like in an QI, quality improvement process. So he was doing well visits. And then a mother brought an 18-year-old in with fatigue. She thought he had mono. He was laying around all the time. And so the nurse was only supposed to screen well visits, but the nurse just knew something wasn't right. So she administered the ASQ. And this is what she got, right? It was one of those rare acute positives. And Dr. Abernathy swears that this nurse saved this kid's life, because when he went in to meet with this kid, the kid told him that he had been caught in an underage drinking party, and his scholarship was in jeopardy, and he had plans to kill himself. So Dr. Abernathy connected him with mental health services and was convinced that had this nurse not had this intuition, that this would have been someone you read about in the newspaper the next day, someone who had everything going for them, but then ended their life. And this was one of the best examples I've ever seen for universal screening, because while nurses save the day all the time, no one should have to rely on intuition. It should just be a systematic thing that's done. So this is, when I was little, there was a cartoon and people would get all animated. They say, don't just stand there, do something. When something happened, right? But this is the case where you don't just do something, you stand there and you listen. And if we all do that and you brace against the awkward and you, if you're a healthcare professional, you do suicide risk screening, then you can save lives. So in summary, medical setting, such an important venue to detect suicide risk. You have to ask directly with an evidence-based tool. Non-mental health providers are also critical partners in reducing suicide. We believe in this three-tiered pathway of the brief screen, the assessment, what does the patient need next? And then the three things that make a difference are the safety planning, lethal means safety counseling, and 988. And this is my thank you slide. I'm happy to take questions and I would love to open it up to the group.
Thank you so much. I even learned some new things today. So I appreciate that. There are a ton of questions. I don't know that we can get to all these. So one of the main ones is, can you share the slides? I can follow up, but can I get this?
Sure.
That would be great.
Yeah, I'll give you a PDF. That's absolutely fine.
Excellent. So when I follow up with you all, you'll get a recording. That recording will have a transcript and you can get the slides. So there are a lot of questions. Do you know on the suicide risk slide, it shows LGB, lesbian, gay, bisexual. Is there a reason transgender individuals are not included because they are at high risk?
So if you'll notice when I did that slide, I did say LGBTQ plus, but there's some restrictions now. So I'll leave it there.
Gotcha. Do you know of any research that is related to local health departments and their role in suicide prevention?
Absolutely. Community health centers are so critical to preventing suicide. If that's what the person means, is that a local health center? Is that what you
I
mean?
assume that's
Yes,
what it is.
absolutely. And that's a place that should absolutely screen for suicide risk as a front line for sure. Absolutely. I'm just
Okay.
thinking of we give presentations for the American Community ACU, I think it's called. We just got asked to speak there. So yes, that's
Okay.
important.
This says, and you'll recognize this one. I would love resources for further training and support on screening youth with developmental disabilities, autism, and communication difficulties. I've run into difficulties in differentiating between scripting and suicidal ideation, lack of understanding of what death and dying is, etc.
Yes, that is. And I feel so passionate about this. We just wrapped up, we tested the ASK in kids with neurodevelopmental disorders through Kennedy Krieger Institute, which is a Johns Hopkins Institute in Baltimore, and Nationwide Children's in Columbus, Ohio. And so we're just looking at the data and it's looking like the ASK is a good tool to use. And I don't know of training videos specific to that, but I know a lot of people I can connect you with that might know that. So please write to me. And if maybe Christina put my email in the chat, or AnneMoss, I'm happy to connect you with them.
I've also, in speaking with people who do the screenings with this community, they like to have the choice whether it's one-on-one or given to them like in an iPad. A lot of them are more comfortable with a piece of technology and putting in their answers there, but not all of them feel that way. The next question is, can Dr. Horowitz speak to recent studies indicating screening tools that are ineffective? The messaging from the recent research feels counterintuitive and is having a negative impact on providers in our area. And I'll put that in the chat so you can see it.
Okay. Um, so I don't know if they're talking about the USPSTF report that didn't have evidence for or against recommending screening, but this is not what we're seeing from research in screening. What we're finding is that now we have a lot of data showing that screening is feasible and it's a really good way to detect someone at risk, and that there's lots you can do. There's one hallmark study that showed that screening reduced suicide, screening paired with a minor intervention reduced suicide attempts by 30%. So we do have a lot of evidence that that screening can be effective. But I know that, you know, pediatricians worry about their waiting rooms and how this is going to open up Pandora's box. But we're really finding is it's not overburdening the system to screen for suicide risk.
So someone asked, is there a difference between the ASK and the Colombia screener?
Yes, there is. So the Colombia, well, I will tell you this, that the Colombia Suicide Severity Rating Scale was made as a surveillance tool when the FDA had a black box warning put on SSRIs. It was not created as a suicide risk screening tool. It was a surveillance tool. It makes a better assessment than a first-line screener. And that's because the screening part of the Columbia actually was never, if you look, you can't find the screener version that was created through research. The ASK actually, I recommend people who use the Columbia to start with the ASK as the primary screener and then use the Columbia as the assessment. The ASK is very quick. It was created through research. It was tested. It was validated. The Columbia makes a better assessment because that's how it was developed and tested that way.
Okay, somebody wants to know what is the source of the statistic that 60% die by suicide with no mental health diagnosis. She's been using the CDC's stat of 53%.
It's Chaudhary et al. 2024, and it's in JAMA.
Okay. I'm curious about the feedback you're receiving in testing the ASK with the ASD-NDD population. In particular, I wonder about the impact of literal interpretation of the final question.
Yeah, so we asked the kids, we did an evaluation of what it was like for kids with neurodevelopmental disorders to be asked about suicide risk, and the majority of them thought it was a good idea. There, you know, some of them felt uncomfortable and talked about that, but a lot of them knew other kids that died by suicide, so they thought it was a good idea. And we're learning a lot from talking to them and understanding. We're also seeing that it seems like it's safe. We put another distraction task in to see if they perseverated on dying by suicide after we screen them, and it doesn't look like they are. So that's another paper that'll be coming out. Can I answer the ASK validated for use with an interpreter? So we recommend that you go to the toolkit and pull up the language that you want for the ASK, because different languages, it's not a one-to-one translation in every single language because of cultural responsivity. So if you don't have that language, you can use an interpreter but we rather you pull up that version of the language you want.
So we're going a little over, And I apologize for those who had to leave or have to leave. But I did want to get a couple more of these questions in. This is from Leah. What are your thoughts on screening in a medical setting versus universal screening in a school setting?
Mm. Well, definitely medical settings, I believe screening has to take place. Schools are where kids are, right? Kids spend 8 hours a day in schools. Um, but schools are tricky, and we do have a school version of the ASQ that we made for many school systems that wanted, so we replaced patient with student. I think a school nurse office is a good place to screen. I think there's programs like SOS. There's two programs called SOS. One's Sources of Strength, one's Signs of Suicide. Those are when you screen in a school, you need a whole entire school approach, right? You can't just start screening. You have to train people on suicide prevention. You have to train the teachers, the administration, the coaches, the kids. How do you recognize suicide risk among your peers? So in a school is a bigger undertaking. I would absolutely screen tomorrow in a school nurse's office. But as far as universal screening in a school, that just needs to be done in a very thoughtful manner.
So I'm going to ask one last one. We still have several here, but just in the interest of time, yours and everyone else's. And I just put it in the chat. Does the risk assessment have to be the BSSA or can it be CSSRS with
No,
safety?
the Joint Commission says you can. Joint Commission says you don't even have to use a tool, but if you're going to use a tool, it has to have certain elements. And two of those elements are risk and protective factors. And the ASK BSSA has risk and protective factors, and the CSSRS doesn't. And that's why it's often paired with the safety. But no, it doesn't matter what tool you're using. You just have to make sure you do a good assessment. The screening tool, I think, does matter. And I say that as not just the ASK, but the PSS3 is a good tool. Evidence-based screener is really important.
All right. Well, thank you so much for being here today. And thank you all for all your questions. And